Well, welcome to the last session. For those of you who stuck at it all day, I'm impressed by your stamina. That's all I can say. I'm joined by my co-chair, Mayor Alma Mar, who I'm delighted to have with us, who is a consultant gynecologist at Imperial College in London, who is a very expert in ultrasound and complex benign gynae surgery, but also our lead for pediatrics and adolescent gynecology. And you can be hearing from Mayor later on when she can be speaking about that, but she's also co-chairing. Lovely to see you, Mayor. I hope someone's in the hospital, but who knows?
Thank you for the introduction. It's lovely to be here. I hope it's been having a fabulous day today for everybody. It's a brilliant program.
Nothing that 6 cups of coffee won't cure. Anyway, I'm delighted always to be joined today by Regina Rosario Panlilio Vitriolo. I love your name, Regina, who unfortunately is not going to be able to do questions because she's not very well, unfortunately. It's also rather late because she is in Manila at the University of the Philippines. And it's an important topic, I think, for this audience, which is talking about abdominal tuberculosis, because it's not an uncommon pathology and often or can look very much like cancer as well. So I look forward to hearing from Regina. I can hand over to her. And I'm then, if there's any questions about TB, I'm going to hand them back to Maya, because I don't see it very often. Over to you. Thanks, Maya.
Good evening from the Philippines. Thank you to the organizers, Professors Tom Bourne and Kypros Nicolaides, for the kind invitation. I'll be discussing pelvic infections, focusing on its clinical and imaging perspectives. I have no disclosures, and this is the outline of this discussion, focusing on PID. So let's first define pelvic inflammatory disease, or PID, according to the Centers for Disease Control and Prevention. This is an ascending infection of the upper genital tract, usually sexually transmitted, and predominantly caused by Neisseria gonorrhea and Chlamydia trachomatis. And this is seen in young sexually active women less than 25 years old with unhealthy sexual behaviors, but the risk is also increased in immunocompromised hosts. Non-sexual transmission may also happen after gynecologic procedures, but this carry low absolute risk. Acute PID is difficult to diagnose because women with PID may be asymptomatic or just have subtle or non-specific symptoms. But in the presence of acute pelvic pain plus one or more of the following considered the minimum clinical criteria by CDC: cervical motion tenderness, uterine tenderness, adnexal tenderness, colloquially known as Chandelier sign, a presumptive diagnosis of PID should be done and patient should be treated accordingly. And this low threshold is very important to prevent permanent tubal damage that can cause infertility. Remember, these are very young patients, and also to prevent chronic pelvic pain. Well, the minimum criteria are sufficient for starting treatment. The following can increase the specificity of the diagnosis. And in more uncertain or severe disease, we can do imaging modalities like transvaginal ultrasound, CT scan, or MRI. But endometrial biopsy may also show endometritis, and the gold standard is laparoscopy, but rarely is this required now because we have better imaging modalities. And while a transvaginal ultrasound has lesser sensitivity and specificity than MRI and CT scan respectively, it remains to be the first line imaging for PID because it has the advantage for pain mapping and for assessing presence of adhesions. On ultrasound, the spectrum of sonographic features would correlate with the progression of the infection, ranging from subtle signs of salpingitis to tubo-ovarian abscess and peritonitis in severe cases. And by duration, it is classified as acute if it's less than or equal to 30 days, chronic if it's more than 30 days, and subclinical if it's of unknown duration. Let's look at subclinical PID. This is defined as upper genital tract inflammation without the classic symptoms or with minimal symptoms, and is often detected in infertility workup, chronic pelvic pain evaluation, as well as for sexually transmitted screening, infection screening. And while there may be no overt sonographic features, there may be subtle sonographic signs that would help support the low threshold for the diagnosis of PID. This would include blurry margins or echogenic fat, which appear brighter or with speculations, surrounding pelvic organs. There can be thickened uterosacral ligaments or complex free fluid in the cul-de-sac. The ovaries may appear enlarged. The follicles are pushed peripherally with prominent borders because of ovarian edema. Again, there can be a peri-ovarian stranding or the bright echogenic outlining because of the inflammation. In the uterus, there can be fluid or debris within the endometrial cavity, such as of early endometritis or indistinct uterine margins or even endometrial thickening. And while the fallopian tubes cannot be seen on normal, are not seen on ultrasound unless they are dilated, there can be subtle thickening already of the tubes. So they now are more prominent, and there can be fluid in the cul-de-sac as well as fluid in the surrounding the tubes. And since the hallmark of inflammation is hyperemia or increased vascularity, Doppler ultrasound may help see this inflammation already, showing the early hyperemia when the grayscale findings are still subtle. And it may help differentiate active PID from chronic disease like tuberculosis, and also be a tool for monitoring treatment response. In earlier subacute PID, there is already increased tubal and periadnexal vascularity. And as I mentioned, the hyperemia may already be observed on Dopplers, even if the tubes are not yet dilated. And the hyperemia are usually seen in the fibrated end in the tubal walls. And on a spectral Doppler, most studies show low resistance arterial waveforms. With further inflammation, the tubes now become more dilated, sausage-shaped, often bilateral, and these are the cardinal signs of pelvic inflammatory disease: the thickened walls, the low-level echo fluid within the tube, which is the intraluminal pus. And when there is obstruction, these pyosalpinges become serpiginous, retort, and even pear-shaped, and more thickened walls. We can see the incomplete septation, characteristic of tubal pathology, and fluid layering or debris within. Sometimes the so-called cogwheel sign is observed, and this is seen as internal mucosal folds within the dilated tube resembling a cogwheel or gear pattern that is a sign of acute infection. When the infection extends to the adjacent ovary, a tubo-ovarian complex is now formed. And this represents early salpingo-ophoritis, where the ovary and the tube are still are recognizable but adherent to each other. You cannot separate them when you do your probe manipulation. It can be tubular cystic, unilocular cystic, multilocular cystic to multilocular solid. And usually they are seen to lie in the pouch of Douglas as opposed to ovarian neoplasms, which are often located anterior and superior to the uterus. With progressive infection, a tubo-ovarian abscess is now formed, and this is recognized as a serious complication of untreated pelvic inflammatory disease. There is loss of normal ovarian anatomy, and the mass is now more complex, cystic to cystic solid mass with complex fluid. This shows a mass that is almost as big already as the uterus. And there can be bright echogenic stipplings due to gas-forming organisms, casting posterior acoustic enhancement, which may be mistaken for air in bowels. So you really have to do your careful examination. And on Doppler, there is the florid hypervascularity because of the ongoing severe inflammation. We can see the florid vascularity in the tubal walls. Sorry. With persistent infection, we have now the chronic PID, which may lead to fibrosis and adhesions, and patients may just be asymptomatic or will just present with chronic or vague recurrent pelvic pain or secondary infertility or menstrual irregularities. On ultrasound, the tubes are now damaged, and we can see already dilated thin-walled tubes, less than 5 millimeter thickness, with incomplete septations, are C or S shape, and on Doppler ultrasound, there is minimal vascularity because already of the fibrosis. And one characteristic also is the beads on a string, which is a chronic hydrosalpinx, where the flattened remnants of the endosalpingeal folds appear as beads or bright spots in a dilated tube. The endometrium may also show signs of endometritis seen as punctate echogenic foci, or there can be interrupted endometrial line which represents uterine synechiae. And hysteroscopy is the gold standard for this. It's both diagnostic and therapeutic. But then we can do saline infusions on hysterography, which may show the adhesive bands traversing the endometrial cavity, but this may not be helpful in near total cavity obliteration. 3D ultrasound may show a more global picture of the deformed and scarred uterine cavity, but they may miss fine adhesions. And one of the more notorious cases of chronic PID is female genital tract tuberculosis, which is caused by Mycobacterium tuberculosis, but the spread is hematogenous rather than sexual transmission. It's quite rare. And unlike the classic PID, which starts from the cervix or the vagina, female genital tract tuberculosis starts in the fallopian tube from a reactivation of a latent infection and then goes to the endometrial cavity, down to the cervix, to the vagina or vulva, or affect also the peritoneum. This is seen mostly in reproductive age women, 20 to 40 years old. They are mostly asymptomatic with infertility in developing countries or menstrual irregularities or chronic pelvic pain. And in postmenopausal women, this is quite rare, but they may present with postmenopausal bleeding or leukorrhea, which may mimic endometrial cancer. Physical examination may be normal in up to 50% of cases, or on examination, there may be adnexal masses, there's ascites or abdominal enlargement, there can be abdominal tenderness, and there's a classic doughy feel of the abdomen when you do your palpation of the abdomen. Due to the similarity of clinical presentation and even sonographic features, genital TB usually mimics other entities like ovarian cancer, endometrial cancer. So a high index of suspicion is always very important. So with classic PID, a low threshold for diagnosis is the key, is the rule. While for genital TB, a strong clinical evidence consistent with active extrapulmonary tuberculosis may already warrant empiric treatment. The gold standard actually is the demonstration of the acid-fast bacilli either through a positive smear or positive culture and cacheating granuloma on biopsies, but this is usually difficult to collect. So again, as I've mentioned, a high index of suspicion is very important. Therefore, a multimodal diagnostic approach or composite reference standard is used to strengthen the diagnosis and is essential for timely intervention. While the absence of ultrasound findings does not rule out PID, in genital TB, imaging modalities are very helpful to rule out other entities like the presence of TB on chest X-ray, to the rule in or rule out ovarian carcinoma seen in CT scan or MRI, the uterine synechiae in the hysterosalpingography, and ultrasound may show the classic features of genital tract tuberculosis. This table just shows a comparison of the sonographic features of a non-tuberculous PID and genital tract tuberculosis. And note, and I'll show you some images later, and note that hyperemia is very prominent in non-tuberculous PID, while it is minimal or absent in genital TB because already of cellular death. The tubes are affected in TB salpingitis in 50% of cases, 90% of cases, usually bilateral because it's the first foci of infection. And the abdominal ends are usually the ones affected rather than the uterine ends. And we can see here that the tubes are rigid and beaded, nodular, and fibrosis and rigidity are the characteristics rather than acute distension. And since the ovaries are less frequently involved due to its tough capsule, most TB adnexal lesions present as tubo-ovarian complexes with discernible ovarian stroma. So even if you see complex masses and it does not rule in a possible non-tuberculous PID, you have to look for the ovaries first. There can be calcifications, or they may present as complex masses already because of cacheating granuloma. So again, a high index of suspicion is important for these cases. The endometrium is involved in 50% of cases. It may be thin or thick or even normal in early disease. Eventually, there can be already irregularity of the endometrial lining because of ulceration, and with persistent ulceration and cacheation necrosis, we have that moth-eaten or serrated pattern, which is pathognomonic for TB endometritis. And cacheation necrosis may actually fill up the entire endometrial cavity, mimicking endometrial carcinoma. But when you put on Doppler, there is no vascularity again because there is already cellular death because of cacheous necrosis, as opposed to the florid neovascularization of endometrial carcinoma. The associated peritonitis may present patients may present already with systemic signs and symptoms like fever, abdominal pain, weight loss, and abdominal enlargement. And TB peritonitis may present as a wet type, free ascites or loculated ascites, or dry adhesive type characterized by adhesions and matted bowel loops. And the wet type may show free fluid, or we can have lattice-like formation, which may appear as a multilocular ovarian mass. But be careful, we have to look for the ovaries here. It's normal, and we can see the dilated fallopian tube here. And in dry type, there's omental thickening, matted bowel loops, and caseous nodules. There is also characteristic peritoneal thickening observed in a TB peritonitis, which is smooth, like a blanket enclosing the genital organs. And this is what I call the pelvic blanket sign. Notice is very smooth here, as opposed to the nodular and vascularized peritoneal thickening in peritoneal carcinomatosis. Other ultrasound modalities that can be used, as I mentioned earlier, for uterine synechiae is 3D ultrasound. For salpingitis, it can also show a better delineation of the tubal architecture, and is very useful in infertility settings. It serves as a virtual laparoscopy, so we reduce the need for the minimal invasive diagnostic laparoscopy because we're able to see already the tubal architecture. And stiffness measured by ultrasound elastography may provide complementary information, but this is still investigational. And future studies may help differentiate acute versus chronic PID versus other pelvic pathologies by assessing tissue stiffness. So hopefully we can have more studies on this. So in summary, transvaginal ultrasound remains to be the first-line imaging for pelvic inflammatory disease, but normal ultrasound does not rule out PID, so treatment should not be delayed, particularly in young women. Female genital tract tuberculosis is a major mimic and a cause of chronic PID in the developing countries such as the Philippines, and it is characterized by fibrosis, distortion, and adhesions, and not florid inflammation like classic PID. Doppler may help us detect this florid inflammation and also help detect early or subclinical inflammation. And we have other ultrasound modalities that can help evaluate the characteristic lesions of PID. But most of all, it's very important to integrate clinical history, epidemiological risk, presentation, and imaging for us to come up with a diagnosis of pelvic inflammatory disease as well as genital tract tuberculosis. Thank you.
Regina, thanks so much. Once again, sorry you're not well and can't take questions. There's a comment in the Q&A. I'm not going to be I'm not sure I can answer the question per se, but I think regarding the question is about whether Doppler indices, RI and PI, are useful in suggesting infection. I think in general, indices of impedance aren't helpful because you're going to have low impedance indices in anything where you get angiogenesis and vascularity, really. So I think as a sort of differential, we went through this with cancer and found it was unhelpful. So I think that's all I can do. And from that point of view, I think the other big issue, don't know what Mayor's view is, since you're there co-chairing, is over differentiating between cancer. And if Regina is here, it'd be very nice to know, because cancer and TB are difficult. I guess one thing I think is the fluid or the ascites With TB, it tends to be a bit more particulate, and you tend to have septations in it and things like that, whereas it tends to be more anechoic or low level. In cancer, the mental appearance is a little bit different. You kind of get a mental cake in cancer. It's more kind of layered and this blanket thing you get with TB. But it can be difficult. I think blood flow is generally a bit less, as she already said, as Regina's already said, in TB as well. It's not quite as hypervascular as you get in acute infection from other types, but also in cancer as well. But it can be difficult, and I think it's a clinical challenge even for people like Regina, who obviously see a lot of TB. For someone like myself, who rarely sees anything like peritoneal TB, it's something you've always got to have in the back of your mind, as it were, if you have a case where it just doesn't quite fit, because it's not that common in our practice, I think.
Yeah.
So it's an important. I don't know. I don't know if you'd agree, Mayor, but
Yeah, I think from it really depends, I guess, what you see in your practice. Because for us, when we see those things, particularly miliary TB, where you might see lots of kind of irregular nodularity in the peritoneum, and as you said, this kind of appearance, kind of spiculated, I guess, appearance of the fluid in the ascites, our first instincts would always go to malignancy, but probably because of the types of patients we see in our units. But of course, it is a very important differential diagnosis. But I'm not familiar with any ultrasound-based data that can differentiate powerfully the differences. But it is a very challenging diagnostic challenge.